Thank you for the invitation to speak. And the topic I've been asked to address is, surprise, surprise, on bipolar. What I wanted to focus today on is an aspect of treatment and relapse that is significantly overlooked, is the whole problem of detection and diagnosis. So just in brief, many of the treatments we have for bipolar disorder are quite effective. Yes, sure, the medication could be better, the treatments could be better, but the biggest area that we fall down on is the whole issue of detection and diagnosis. So what I want to start with is by just looking at this word, I feel depressed. If a person has a feeling of depression, it doesn't necessarily mean they're clinically depressed. But unfortunately, if a person says it again and again and again, intensely, it becomes the label, i.e. that person is depressed, that sticks. And the problem is that we have 3 Ds, distressed, depressed, and dysphoria, which I'll come to in the next slide, that indicate quite clearly that we have to have a greater understanding of the word depression and what depression is made up of. So when somebody is distressed, they may say they're depressed, as the person who's depressed can say likewise. The difference is that distressed state is a state of anxiousness, being annoyed, frustrated, bothered, weepy, a bit agitated, maybe not sleeping that well. Whereas the person who's depressed is flat, dull, withdrawn, quiet, subdued, looks dull, and that's the picture. So that core picture of depression, if it's not there, it probably isn't depression. When it comes to dysphoria then, the overlap between dysphoria, which is a type of unpleasant high, or what's also known as a mixed mood state, the overlap between that and depression is extremely high. Almost all other symptoms are the same, but there are a few distinguishing symptoms that are worth highlighting. People with dysphoric hypomania, i.e. unpleasant high, have trouble getting to sleep at night. They tend to feel worse in the evenings. There is a lot of irritability and anger, and very often the person is weepy. Now, weepy, no, you couldn't hang your hat on that. But supposing somebody, you're trying to work out whether that person is in a dysphoric hypomanic state or depressed. The curious thing is that people who are clinically depressed don't tend to cry because their emotions are flattened and they can't cry. Whereas somebody in a dysphoric hypomanic state can actually be extremely weepy. But the 3 core things are the 3 above: the anger, the evening worsening, and the trouble getting to sleep at night. So if you extend this out a bit, if somebody says they're very depressed and they've been depressed for ages, if they normally sleep well when they're feeling well, and now they've trouble getting to sleep at night, there's a fair chance actually that that's not depression. So once you dig beneath the surface of these things, you can see that there's a whole other web of understanding and information there that to make headway in terms of detecting and diagnosing depression and bipolar disorder, we've got to take account of. So the key aspect of bipolar disorder, it's an alternating state or an alteration in the rate of psychomotor activity. Psycho means mind, motor means motor in the body. So in other words, a slowing of the mind and a slowing of the body in depression, and in elation, it's speeded up. Both are speeded up. And that should be visually obvious to somebody who is in that state. If you can't see that, you've got to question, well, maybe it's not that. So it's alternating bouts of depression and elation is the core feature of bipolar disorder. There are some people at the early stage of their illness, particularly if its onset is in the teens or 20s, they may have recurring bouts of highs and no lows worth talking about. But if you follow that person's pattern over the years, and if they're still relapsing in their 40s and 50s and 60s, it'll go to a more elation depression type pattern. So as I said at the outset, the treatments aren't bad. I'm not saying they're great, but often the focus for people who don't respond to treatment for bipolar disorder is nothing works for me. The frequency of the diagnostic issue mustn't be underestimated, because it is actually a very frequent explanation for why people apparently don't respond to treatment. So it's the lack of recognition. In other words, that the person doesn't recognize it within themselves. It's under-detected then at the clinical level, and then it's underdiagnosed even when it's known the person has some mental health difficulty. So at 3 different levels, the level of undetection, under-recognition, and underdiagnosis are important. The statistics on this statement may have changed, but I don't think they've changed all that much. 50% of people who are clinically depressed in the community, in everyday life, do not recognize they're depressed. Probably they've been so long in the state, they just see it as part of everyday living, or they're too ashamed to acknowledge it, or maybe there's nothing can be done about it. The other 50% of that, half of that remaining 50%, when they do go for treatment, get adequate treatment. So about 25% of people who are clinically depressed in the community end up getting satisfactory treatment. Another thing to note is that 45 to 60% of people with clinical depression who have been treated for clinical depression in an outpatient's department have actually got bipolar 2 mood disorder. So if you use the criteria that are required to diagnose bipolar illness, you will find that many, many people have bipolar. They report depression, but if you dig into it and ask the right questions and interview relatives and get all the stuff together, that's what emerges. So it used to be thought that bipolar disorder was a relatively uncommon condition in the sense that it affected 1% of the population in the course of their lifetime. Doesn't mean that each year 1% of the population start having bipolar disorder. It means that if you take a whole person's lifespan, about 1% of people go through it in the course of their lifetime. More recently, it's become aware that the lesser degrees of bipolar disorder, both bipolar 2 and even more minor degrees of bipolarness called bipolar spectrum disorder, are much more common. And it's now, that figure is put conservatively at 5%. Other people would put the figure much higher, but I think it's too early to be jumping to conclusions. You won't see bipolar spectrum used in any of the official classifications, because frequently the classifications of these things are behind the research and science in this area. And because it's bipolar spectrum disorder doesn't mean that it's an innocent and mild condition. It's quite upsetting for the people concerned, because people with bipolar spectrum disorder, that's almost sub-syndromal elation, have a 4-fold increased risk of having a suicide attempt, of having more frequent attendances at OPD and at A&E, medical OPD and A&E, of being recipients of disability benefit or welfare benefits than people without a mental health problem. So really what I'm trying to get across is, even though we're talking about something that is less than bipolar 2, it still has a significant level of upset. They have quite a degree of disability associated with it. So hypomania in those with depression frequently goes undetected for 2 reasons. One is that if it's a pleasant elation, the person has nothing to complain of. so they won't mention it. If it's an unpleasant high, a dysphoric hypomanic episode, the person will frequently say they're depressed. These are the problems that one runs into from a diagnostic point of view. So when you look at this, what's the outcome of all of this? Well, frequently it is the problem of trying to detect bipolar disorder and to look at predictors within a group of people from a clinical point of view that might be helpful. So if you have people who have recurring unipolar depression at an earlier stage in their life, you can sometimes predict whether that person is likely to go on and develop bipolar disorder. Sometimes if the person has a very early age of onset of the depression, or if they've had multiple episodes of depression at an early age, if they complain of racing thoughts during episodes of depression, if they tend to overeat and have significant weight gain as part of their depression. The next one is particularly important. If the person, when they're depressed, has very marked slowing of their mental and physical capacity, in other words, that psychomotor slowing I mentioned, that would tend to be a harbinger or a foreteller of the likelihood that the person may even be having quiet episodes of highs, or that they're going to get them in the future. A poor or short-lived response to an antidepressant is another indication. So what happens is the person with the depression is given the antidepressant, they come out of it, go a bit high on it, which goes unnoticed, and then they go down again. So it's said they fail to respond to the antidepressant. But what has actually happened is that the antidepressant has lifted the person's mood, and then because they went into a high, it drops out of it, even though they're still on the antidepressant. A history of bipolar disorder in first-degree relatives in people with depression is an indicator, or multiple family members having a history of unipolar depression. If the person has, as part of the depression, psychotic features, or if it's a postpartum onset, that's after the birth of a baby, postnatal depression. If the person has manic symptoms when they've been given ECT for the treatment of the depression, or, as I said, if they have a manic symptom after an antidepressant, or if they have a hyperthymic personality. Hyperthymic personality is where the person's mood or personality base is a bit on the edge of high, but not quite there. In other words, that's the personality they have, as opposed to somebody who'd have a depressive personality who's at the lower end of the spectrum. They're not depression, it's just part of, in a sense, the person's makeup. In studies of young adults who have depression, the breakdown amongst those, we said the 46% of people who have bipolar disorder, in other words, when they're examined more correctly, what you find out is that 46% of them have bipolar disorder, comprising of 19% with bipolar 1 and 27% with bipolar 2. So in terms of educating people about the symptoms of bipolar and being able to predict or detect a relapse at an early stage, there have been enormous randomized trials where people have gone to educational programs to learn these symptoms and so forth. And yes, the evidence is it is effective and does help enormously with the person's management. So how to recognize hypomania, or the lesser degrees of it? Well, you can look at the signs and symptoms of mood problems, and they sometimes will be of help. But the trouble is with a pleasant high, frequently the person is not going to be able to detect it at an early stage themselves. Because what is trouble getting to sleep at night? Is it when it takes you 5 minutes, 20 minutes, half an hour, or 2 hours? What is feeling good? as opposed to feeling excited or feeling high. In other words, there's no cut-off point in the person's mind. When it's depression, when you feel bad, it's different from not feeling bad. It's not a continuous phenomenon. The person themselves will frequently know when they've got a feeling of depression. So the next way to look at the recognition of hypomania or highs is to look and see if the person has got a personal sign. Most people, when their mood changes, either high or low, their thinking pattern becomes quite restricted and will often come down to a certain 2 or 3 things that the person will get preoccupied with. Somebody who is depressed might feel they're hopeless at their work or they're a bad parent, and otherwise that thought isn't on their mind. Somebody who is high might wear a certain item of clothing or want to undertake some work around the house that is reckless, taking off the roof of the house in the middle of winter or something like that, and they think nothing of it. Now, it may be, yes, it's a valid thing to do, but maybe making sure you had enough money, that you had rented some other place to live in the meantime, and so forth would be helpful. The point about those personal signs is that frequently families will spot those personal signs. They will know as soon as they see John having a smoke when he normally doesn't smoke, they know that that's an indication that his mood is going up, because every time he's gone up previously, he had smoked beforehand. Now, it's not saying that the cigarettes contribute to it itself, it's just a sign. The most reliable way so far that we know of helping people spot a relapse, particularly a relapse into a high, is having a spotter in one's life. Spotter being the term that aware support group attenders have come up with, and the thing about it is that frequently the family will spot a person's change of mood into a high very quickly. The tone of their voice, the way they cock their head, the volume of their voice, what they're up to, what they're talking about, how much they're eating, just little things like that. Even over the phone, these things are detectable. But frequently that the person in the high state is very reluctant to accept what's being considered or what's on the mind of the relative. What we advise people to do is that family members should be aware of the illness, and the person who has bipolar should ask a trusted member of that family to be their spotter. Now, by a trusted member, I mean is somebody who they see quite frequently, preferably somebody that they live with, because things can change from day to day or hour to hour in this respect, and if the person has not been in contact with any family member for quite a period of time, it's not much point in having a spotter who's living in Chile or whatever, and expecting it all to work out dandy. So it's up to the person with the condition to invite a person to undertake this verbal or sometimes written contract. Tommy, I give you permission to take away my car keys if you think I'm high, and if you want to take away the credit cards and so on, or if you think I need to go to hospital, please tell me. Not an easy thing to surrender your independence to anybody, including family members, and it's particularly difficult if the person is going to be in a high state when they have to do that. So the earlier on in the condition that the intervention is made, the less intervention is needed and the less troublesome it will be. So treatment at an early stage is often the thing that is, life-saving, stops families breaking up, stops the person having to take time off work or even go into hospital. So for people who have difficulty accepting that idea of asking a family member, what they've got to choose between. Do I trust my family member to do the right thing, or do I let the bipolar illness determine what I do? Because really that's what it comes down to. For people in the early stage of the illness, this is probably the key thing that makes a difference in the person not having relapses. I've no doubt about that. Another two ways of helping to detect mood changes is looking at having a mood diary that keeps a daily log of how the person is. The trouble sometimes with logs like that, they're useful up to a certain point, but unless the person does the log around specific definite symptoms that they've been guided to that are relevant in the context of depression or bipolar disorder, it's probably not going to be all that relative. And the other way then is a mood graph, which can be useful, and these are often done, we say, for putting in a diagnosis of depression on a 3-point scale: 0, no depression, 1, or I should say -1, mild depression, -2, moderate, and -3, severe, and likewise on the plus side for elation, +1, +2, +3. The trouble with those again is we come back to this sort of single word to describe everything, i.e., well, the person is saying they're depressed. My experience with people using those graphs over the years is that frequently people will say who are in an unpleasant high state are marking that down as depression. And then you have to go through it in detail with them to work out, well, what exactly was that 2-week period of being below the line mood-wise. So over the past 30 years, there's been an increasing recognition that bipolar disorder is relatively unrecognized because of its diverse and subtle manifestations. The consequences of not recognizing and diagnosing bipolar disorder is the person will often be, the top 3 statements there about things failing, i.e. treatment failure, failure of antidepressant, or being diagnosed with treatment-resistant depression. Just using those terms, kind of almost the same thing, but you may hear of them and wonder what they mean. So basically what's happening is there's a mismatch between the diagnosis the person is working on and the treatment they're getting, because they may be being treated for a recurring depressive condition or a prolonged depressive condition, whereas in fact half the symptoms may be due to an unpleasant high. The second category of problem then is the tendency to recognize it because the person is having lots of mood disturbance, maybe rapid cycling moods, and they end up being diagnosed as having borderline personality disorder or emotionally unstable personality. In other words, that it's part of their personality makeup and it's deemed to be an interaction with the world around them and with their family and so on. Again, because at certain phases of bipolar disorder, the person's emotional fragility is such that they will tend to row and fall out and be upset with family members. And at those points in the condition, it can be hard sometimes to diagnose. Personality disorders generally as well, not referring to that specifically here, can be overstated in these situations. There's an increased amount of suicidal activity as a failure to diagnose bipolar disorder, including and also relationship and employment, drug and alcohol problems. So it's not insignificant. It may interest you to know that 31% of days of depression and 14% of days of elation recorded by patients. In other words, if the patient is independently rating their own mood or keeping a diary of how they are each day, if they then each week now, not each month, each week, if they go into a clinician who examines them and makes a note and estimates how much of the week they've had depression and elation. They only pick up 31% of the days of depression and 14% of the days of elation. Now, many people coming along to an outpatient department come once every month, once every 3 months, once every 6 months. So you can see how a lot of information gets overlooked, and thus why people frequently end up having relapses. So daily mood monitoring is an important part of all of this. So we need an increasing awareness of early symptoms of relapse, and daily mood monitoring helps that. It's less likely to overlook the key symptoms of depression if the mood monitoring is effective. It will also pick up rapid cycling mood disorder way before any clinician will. Again, if it's done, if the monitoring is done properly. Even if the person doesn't have overt symptoms of depression or elation as time goes on, but they have what one would call residual symptoms. Maybe their sleep pattern didn't come back fully to normal, or their concentration isn't as good, or their energy. That's often a forerunner of getting high at a later stage or low. And that's where the intervention and managing those minute symptoms becomes important. Another part of keeping a mood monitor and a thought monitor is thought awareness improves and aids CBT. In other words, once a person keeps a log of their thoughts, they become aware of what they're thinking. See, frequently we think we're aware of our thoughts, but we're not. Until you write them down, you don't realize, oh gosh, look what I'm saying to myself, or look what I'm thinking. And to engage, for example, in CBT, that's probably, well, not probably, is the very first step, because just creating an awareness of the thoughts that we have is often the first step in seeking or making some sort of recovery. Now, the problems with daily mood monitoring is this. Frequently, there's poor compliance. People just couldn't be bothered doing this. Another one is people filling in their questionnaires in the waiting room for the previous week just before they go in to see the doctor. Sometimes they get their dates mixed up, so it's pretty obvious. If the data the person brings along is being put into a system to try and measure the whole thing, it's actually quite a time-consuming and expensive job. People will often say that they find it emotionally distressing to face their thoughts and their emotions and to log them each day. And in that sense, it can be a little bit like going to psychotherapy, facing the feelings, the upsetting feelings. But again, it's an absolute necessity to face those and address them, or just face them before you address them and measure them, because it's the most effective way of keeping mood stability. Even with mood monitoring, self-reporting of manic symptoms may not agree with the observations that a clinician might make. So you might have a person who'll fill in the stuff, fill it in even if it's the best questionnaire out, but a clinician observing the person will often be able to see that they're not well. So more recently, there's been an interest in using smartphone technology to look at, is there some other way you could measure moods in an effective way? And they fall into two categories. One is where it's questionnaire-based, and the other is where it's part of the smartphone technology that I'll come to in a moment. So when it's questionnaire-based, it's giving the person a questionnaire within the app in the phone and collecting the information and processing the outcome in that way. For the vast majority of apps that are available for measuring mood, they assume that the word depression means depression. So in other words, there's no depth to them. It's a very superficial thing. There's no cross-referencing of maybe the 10 most common symptoms of depression, or elation, or unpleasant highs, or anxiety. Because you see, with people who go through mood swings of any sort, there's often a mixture of depression happening, unpleasant highs, anxiety, and features of borderline personality. So often these things have got to be teased out from one another to make any sort of sense. By and large, there hasn't been much headway with the questionnaire-based ones in that sense. So most of them don't meet ordinary clinical criteria and are rated under the category of lifestyle choices on the App Store and Google Play. So in terms of the smartphone, more recently there's been a lot of money spent on investigating whether, by measuring certain things within the person's iPhone, for example, or Android, such as the length and duration of the person's emails, phone calls, or texts. So in other words, they shrink when the person is depressed, they're excessive when the person is high. And then on the geolocation, if the person doesn't switch off their location, you can see how much they've been moving around the place. Big Brother is coming. By and large, the results from these things have not been impressive, because it's obviously quite complex. You know, you've got to allow for things like a boil notice appearing on in North Dublin, Meath, Kildare, and wherever, and 600,000 people have to boil their water, and they're scurrying around from one supermarket to another looking for bottles of water. How is that going to show up on an app? Does it mean everyone has gone manic on the north side of the city? So there are a lot of things in terms of holiday, what the person is up to, physical illness. There are a lot of things that would intrude on the thing, apart from the whole issue of a person's privacy. So it's hard to know where all that's going to. No formal thing has emerged from the research in terms of anything. One I've been involved with is a thing called MoodView, and it requires people to make a daily entry into the app, and it asks questions, something like this, asking a person along the slider to choose a figure between 0 and 10, 10 being the most intense feeling of depression, asking about feelings of feeling great, and choosing a bar there that represents where the person is feeling. Unable to trust, hurt by people or events, and the person's level of energy from mildly to moderately reduced, and on the upper side then, slightly, moderately and greatly increased. Outlook for the future in terms of being hopeful, positive, bleak, blank, I wish I didn't have to keep living. Then this produces a score on anxiety, depression, elation, unpleasant high, and emotional reactivity. And the scoring there is that the person has a score of 14% on elation and dysphoric hypomania of 12. So that's on the 1 day. So that's just a score for 1 day. We'll come back to the commentary there that follows that in a moment. Now, these ratings have been shown to be clinically valid. In other words, if you get people to fill in the MoodView app and rate their mood, you will find that if they're independently examined by a psychiatrist measuring their mood, there's no great difference between the scores that both would get. In other words, it is valid in that sense. So what's basically showing there is the person is going through an unpleasant high. So with this, you can tap any of those buttons. Any of these buttons here will bring up the relevant mood state. You can have all 5 of them pushed at the one time, but just for clarity, it's useful to see this one here. Okay? So the person was going through an unpleasant high at that stage. The cutoff point for that, which is not on that graph, between that and being probably or possibly clinically significant, is that level. I might add, and this is important, this is not a diagnostic instrument. It's to measure the moods. It's designed for people with depression. It's designed for people who have been given a diagnosis of depression or of bipolar disorder. It's not an instrument to diagnose depression or bipolar disorder. Now, just going back to this one. And we don't see which button is pressed here, but anyway, that score, that's the anxiety score. Okay? Now, the interesting thing is what that person was complaining was of anxiety. And they were being treated for anxiety. But when you went and looked, the peaks here coincide with the peaks on the anxiety scale. Now, there are 2 peaks there, so they coincide. So here we have dysphoric or unpleasant high being the core symptoms, but piggybacked onto that are symptoms of anxiousness. What this helps to do is to separate the 2 out, and what becomes clear is that when the person is given something to treat the dysphoric hypomania, the anxiety disappears. Okay? Now, this is another interesting one. The person, so we've got the sort of cutoff points for the different mood states here. I'm afraid I'm colorblind, so I'm not particularly good at this, but here you've all the mood states switched on: dysphoric, elation, depression, anxiety, and emotional reactivity. And this one bopping along here is the anxiety. Okay. Now, when we go along, this is in the same person, and same thing is happening. So what the person was complaining of was that they were having episodes, sort of an anxious, depressive phase here. Now, it looks as if it's only for 2 days, but he hadn't completed the questionnaire there or there. But even here, you had a fair bit of anxiousness. But lo and behold, here we have a sort of a sub-syndromal, not fully meeting the cutoff point here, but pretty much up next door to it, you have an unpleasant high. The point being that the person's mood is actually swinging all the time a little bit. By treating this unpleasant high, all these symptoms cleared up. By treating it as anxiety initially, nothing worked. It's only when he completed this questionnaire, it became clear what was happening, that his mood swings, in a sense, were driven by an ongoing high, which is not surprising because prior to that, at an earlier stage, he was being treated for rapid cycling moods related to antidepressants, and being on a mood stabilizer, his mood was settling, but hadn't settled fully. But it was then very easy to address the thing once the app gave a hint of what the problem might be. So just going back to the commentary. Now, the commentary might seem a little unusual, but what it's saying is the intensity of your mood symptoms today are unlikely to be having any upsetting or disrupting effect on your life, based on what other people report when they have similar scores of mood, which is fair enough. In other words, that it hasn't gone up above the cut-off line that is internationally accepted as a cut-off point in a clinical sense. Your outlook for the future, as reported, was positive. Do remember to share your moods with your clinician or therapist at the next meeting, where you can email the results to them. And there's a graph and commentary. And it encourages daily rating of moods rather than relying on a few days' ratings. In terms of the security around this, there is no login. MoodView does not retain any data. It does not require even the person's email address. There's no name, there's no nothing. So when the stuff is printed out within the system, it's up to you, or the consumer, to do what they want with it. So we've a good bit to go in terms of the recognition of this problem at an everyday level within mental health, within general practice, among psychologists, therapists, counsellors, and so forth. It's quite a significant problem. Once detected, it's quite easily addressed, and it probably explains a large proportion of the people who have treatment-resistant moods or treatment-resistant depression. Well, thank you.